Hello friends, I am Dr. Shonali and let us begin the GT 180 grand test and the OBS gynae part. Let us study, let us read the questions and let us discuss the questions hereof. Okay. So coming to this, let us see these questions. Let us begin with question number 210 here. Alright. So the question says following procedure can be done for all of the following except, okay, A as an approach for tubal sterilization, B removal of fibroids or myxoma, C removal of displaced copper T, and D drainage of pelvic abscess. Alright. Now the answer to this question is option number C. Okay, the answer is option number C. All of the other things can be done from this procedure except removal of displaced copper T. And now as you can appreciate in this figure here, what we are doing, we are reaching via the posterior fornix. Okay, so from the posterior fornix here, a scissor has been, a forceps has been inserted to open this posterior fornix and gain access to the posterior part of the uterus. Okay, from this posterior part of the uterus, sometimes this procedure was done in the past, okay, to remove fibroids of myxoma. If the fibroid is lying somewhere here, then it could be removed. I'm so sorry about this. Fibroid could be removed, tubes could be grasped from the posterior aspect of the uterus and that could be used. Pelvic abscess, any collection in the pelvis, any collection of pus in the pelvis could be drained via this approach. But removal of displaced copper T, now a copper T is actually inside the uterus, okay. When it gets displaced, it either gets displaced and remains inside the uterus or goes up inside the abdomen, okay. So removal of displaced copper T is difficult or is not not done via this procedure. So let us just see, let me just show it to you here. As in question number 210, the correct answer is option number C. And if we can see what they are doing is, let me just give you a zoom in sort of a diagram for this question. We have the uterus here. Okay, this is the rectum here and the gut and everything, and we have to appreciate that the posterior aspect of the uterus, the peritoneum, covers like this. So this is something which is called as the pouch of Douglas. Okay, posteriorly, anteriorly the peritoneum goes towards the bladder. This is the bladder here. Okay, so you understand, anteriorly the peritoneum, reflection of peritoneum is higher, and posteriorly the reflection of peritoneum is much lower down the posterior surface of the uterus. So this is it is possible to access this space via the posterior fornix of the vagina. Now this procedure is called as posterior colpotomy, posterior colpotomy. Alright, and there have been times when, let's say, there is a fibroid here, myoma here, that can be approached via this approach, and this fibroid can be enucleated. Okay, posteriorly the tubes are there, the tubes can be approached via this approach, the tubes can be pulled down and then ligated. So it was possible to it was possible to remove a myoma from this approach. It was possible to ligate the tube from approach. Both these approaches as standard procedures for myomectomy or standard procedures for tubal ligation are not done anymore. Alright, so it was possible, yes. It is possible to drain any collection here of pus. So pelvic abscess drainage can be done. But see, if there is a tube, if there is a copper T that has been displaced, that is not removed via this approach. So what do you do for a displaced copper T? For a displaced copper T, if the copper T is in the uterus, it can be removed by hysteroscopy. Hysteroscopic removal. But if the copper T has displaced and moved out into the abdomen, then that needs to be removed by laparoscopy. Okay, so this is about this question, and this is about the displaced copper T. Let us move on to the next question. Question number 211 here. All right. A 25-year-old woman with a history of 2 spontaneous abortions, okay, so 2 spontaneous abortions, has a positive RPR test. Now, what is RPR? RPR is a VDRL. It is another test, it is another name for the VDRL test, and there is a negative FTA ABS test. So, what has happened in this? The screening test for syphilis has come out to be positive. This is the VDRL test which screens for syphilis. This test screens for syphilis, and there is a negative FTA ABS test which is a confirmatory test for syphilis. So the screening test for syphilis is positive, but the confirmatory test for syphilis is negative. So the woman does not have a syphilis but has a false positive test for syphilis, false positive screening test for syphilis. Her pelvic exam is normal. Which of the following management plans would be most useful in this patient? A dark field examination of vaginal secretions, a VDRL test, a test for anticardiolipin antibodies, or treatment of the patient with penicillin. So, a dark field examination of vaginal secretions will yield nothing more because the confirmation of syphilis has already been done. She does not have syphilis. It is negative. The FTA ABS test is negative. A VDRL test has already been done. Okay, so this is just a confusing given option to confuse you. Treatment of patient with penicillin. Why will you treat the patient with penicillin when the confirmatory test for syphilis is negative? Look at option C, a test for anticardiolipin antibodies. Yes, that is what is your answer, a test for anticardiolipin antibodies. Why? Because the clinching diagnosis here is 2 spontaneous abortions. So recurrent, 2 spontaneous abortions, recurrent APLA. Okay, so there is a condition called as antiphospholipid antibody syndrome. Let me write it down here for the discussion for the next question. There is a condition called as APLA, that is antiphospholipid antibody syndrome. And it leads to second trimester abortions. It leads to second trimester abortions, and it can lead to recurrent second trimester abortions. And with this test, there is sometimes false positive VDRL. False positive VDRL can be there with this test. Okay, false positive VDRL can be there with this test, and therefore now we'll have to confirm for anticardiolipin antibodies. Okay, now you will have to, what is the lab tests? What are the lab tests which we do for APLA? The lab tests that we do for APLA are anticardiolipin antibodies. Anticardiolipin antibodies. We do lupus anticoagulant. If the option had lupus anticoagulant, that will be your answer. Okay, we have to do all these. In the option, anticardiolipin is given, so that is your answer. The other antibodies which we do for APLA are lupus anticoagulant, and the other that we do is beta 2 anti-beta 2 glycoprotein antibodies. Okay, so this is why the answer for this question is option number C. We will now test for anticardiolipin antibodies. Alright, let us move on to the next question. Question number 212. this question here. Now, a 50-year-old woman presents to you with mood swings, okay? So 50-year-old woman presents with mood swings, hot flushes, night sweats and absence of menses for the last 5 months. Her pregnancy test is negative, which is the most useful in workup of this patient. So the answer, is it estradiol level? Is it TSH level? Is it FSH level? Or is it serum prolactin level? Now the correct answer is option number C. The correct answer is option number C, serum FSH level. Serum FSH level is our answer here. Now what is happening with this woman? She is 50-year-old, she is having mood swings, hot flushes, night sweats. These are all menopausal symptoms, okay? These are all menopausal symptoms, but she has absence of menses only for the last 5 months. Now we understand that the diagnosis of menopause is mainly a clinical diagnosis. Let me just write it in the next sheet here. That is, writing is easier there, okay? So we all know we are discussing now question number 212, okay, where the woman is a 50-year-old woman. She came with hot flushes, menopausal symptoms, and she had amenorrhea for 5 months. Now we all know that the diagnosis of menopause is a retrospective clinical diagnosis. The diagnosis of menopause is made how? When the menses have been absent menses for a period of 1 year, so 12 months. But this woman is having symptoms of menopause, but amenorrhea for 5 months only. So therefore now we can confirm it by serum FSH levels, and serum FSH levels we know are going to be raised. Okay, serum FSH levels we know are going to be raised in this situation. All right. Why did we not go for estradiol testing? Estradiol is also going to be less in menopausal status. Okay, when the menopause is achieved, estradiol will also be low. The estradiol will also be low, but the better values to confirm diagnosis is actually serum FSH, not low estradiol levels. Okay. Now, by this, what is the cause of these hot flashes? Okay, so she has amenorrhea for 5 months only, but what is the cause of these hot flashes? So remember, this is one thing I want to tell you, one additional point here. What are the cause of these hot flashes? The cause of these hot flashes are estrogen deficiency. They are also serotonin deficiency and increased norepinephrine. Okay, so there are these hot flashes are multifactorial. They are thought to arise because of estrogen deficiency, because of serotonin deficiency, because of increased norepinephrine in the brain. So these are some of the causes that have been, some of the reasons that have been implicated in the pathogenesis of these hot flashes. And when a menopausal woman has hot flashes, she needs hormone replacement therapy. Okay, when a menopausal woman has hot flashes, the treatment for these hot flashes is hormone replacement therapy. Hormone replacement therapy. And remember, if the woman has a uterus, then the hormone replacement therapy is estrogen plus progesterone. And if the woman has no uterus, let's say for example she had a hysterectomy in the past for some reason, if she does not have a uterus, we can give estrogen alone and leave out the progesterone. And remember that if she has contraindications for estrogen. Now, estrogen is a drug which has a lot of contraindications, absolute contraindications, right? For example, venous thromboembolism being one, and active liver disease being the other. or coronary artery disease, then we can use SSRIs, selective serotonin reuptake inhibitors. Then SSRIs can be used instead of using estrogen, okay, not progesterone. Okay, so hormone replacement therapy, treatment for hot flashes, needs estrogen. If the woman has a uterus, she will additionally need a progesterone also. If she has no uterus, estrogen alone can be given. If estrogen is contraindicated for some reason and this woman needs treatment for hot flashes, she will need SSRIs that can be used. Now, let us move on to the next question. Question number 213. Question number 213. Which of the following statements is incorrect regarding levonorgestrel releasing intrauterine system? Okay, so we are talking about the levonorgestrel releasing intrauterine system, which is also called as Mirena. So we are talking about Mirena. Which of the statements is incorrect? A, there is increased incidence of menorrhagia. B, this system can be used as hormone replacement therapy. C, this method is useful for the treatment of endometrial hyperplasia. And D, irregular uterine bleeding can be a problem initially. So the correct answer is option number A. There is increased incidence of menorrhagia is the false statement. All the other statements are true. Okay, all the other statements are true. So talking about Mirena, Mirena is in fact used for the treatment of endometrial hyperplasia. It is in fact used for the treatment of abnormal uterine bleeding or excessive uterine bleeding. So it is a treatment for menorrhagia. Menorrhagia is not a side effect of Mirena. Okay, and this system can be used as a hormone replacement therapy. Yes, like just before this question we discussed that if you want to give a hormone replacement for a woman with hot flashes, a menopausal woman in the presence of a uterus, you will have to give estrogen plus progesterone. So estrogen she can take orally or there are transdermal patches available, and for the progesterone you can insert a Mirena for that woman. So the advantage of Mirena is it will give local, it will give progesterone, release progesterone locally. That is what is the advantage, because it is inserted in the uterine cavity, and so there is local release of progesterone, there is local release of progesterone. So even small amounts of progesterone will do their job inside the uterine cavity, and then what will happen? There will be less systemic side effects. So coming to just a few important bits I want you to remember about Mirena. They have asked Mirena a number of times in the examinations, okay? And so just let us see, let me give you comparative between Mirena and copper T, because sometimes they ask this question where they will confuse you between these two intrauterine devices. Both are intrauterine devices. Okay, Mirena contains the LNG. LNG is levonorgestrel. Copper T, obviously you understand that it contains the copper ions. All right, so it is copper. A wire is wound around it. Mirena looks like this. It is a T-shaped device and there is a cylinder here. Okay, this is a cylinder. So the drug is on this vertical limb. In copper T, there is a brown colored ring which is woven, brown colored wire which is woven on the vertical limb as well as on the arm. So this is about the appearance of the devices. Apart from that, both can be used as contraceptives. Both can be used as contraceptives. Okay, but the mechanism of action is different. For copper T, the mechanism of action is inhibition of fertilization more than it inhibits implantation. Okay, So copper ions are basically toxic to the sperms, alright. So the main mechanism of action is inhibition of fertilization, and it also inhibits implantation, but fertilization inhibition is a more important mechanism of action. With Mirena, the mechanism of action is inhibition of implantation. Okay, it is inhibition of implantation. All right. Now, the other important aspect to remember in Mirena versus copper T is that the lifespan. Okay, the lifespan of, remember the lifespan of copper T when they are used as a contraception. Copper T is 380A is 10 years, and for Mirena the lifespan is 5 years. Okay, so remember, as a contraceptive agent the lifespan of Mirena is 5 years. But if they ask you specifically, Mirena keeps on releases the drug for a period of 7 years. Okay, but after 5 years the contraceptive efficacy decreases. Okay, now what about the next point to remember, the difference between the two? Remember, what is the failure rate? Okay, now the failure rate of copper T is around 0.3 to 0.8%, and that of Mirena is about 0.2%. So Mirena failure rate is lesser than the failure rate of copper T380, and Mirena is very, very effective. In fact, they say that Mirena is as effective as tubal sterilization. It is as effective as tubal sterilization. These are all important one-liners about Mirena which I am coming across, so please remember them. Okay, Mirena, they say it is as effective as tubal sterilization. So this is another point. Then the other point is two additional important points. Copper T380A is used as, it can be used as an emergency contraceptive. Copper T can be used as an emergency contraceptive. In fact, they say that it is the best emergency contraceptive, and it can be inserted within 5 days. It can be inserted within 5 days. All three important points about copper T380A. All right, but Mirena on the other hand cannot be used as emergency contraceptive. Mirena cannot be used as an emergency contraceptive, but it can be used as treatment for menorrhagia. Okay, it can be used for treatment of menorrhagia. And Mirena on the other hand, what will happen after insertion of Mirena? Remember that Mirena, it does not inhibit ovulation. Remember, it does not inhibit ovulation. First point is this. Second point to remember is that it thins the endometrium. That is why it is used for treatment of hyperplasias, treatment of endometrial hyperplasias, because it really thins the endometrium. And because it thins the endometrium so much, the side effect of Mirena is irregular bleeding, but that bleeding is not severe, that bleeding is not much, it is only spotting. Okay, so only episodes of spotting can be there with Mirena. So that is the thing. Important aspects of Mirena versus copper T, a must to remember. All right. Now, let us move on to the next question. Question number 214. Question number 214 here. Water content of Liker amni is said to be replaced every 3 hours. Water content. Now this is a direct one-liner question. Okay, there is no explaining. You have to read this. Water content of Lycaramni is said to be replaced once every 3 hours. Okay, so so this is what is important. And Lycaramni is as such also an important topic for your NEET PG exams, because you know a lot of one-liners are asked on your Lycaramni. Yeah. So a lot of one-liners are asked on your Lycaramni. So we're discussing question number 214, and we are talking about the amniotic fluid. We are talking about the amniotic fluid, and I want you people to remember that the main content of this amniotic fluid is water. Okay, and this water, we have just now answered the question, that is replaced every 3 hours. Okay, and they also asked this question on the amount of amniotic fluid. The amount of amniotic fluid is maximum between 32 to 34 weeks of gestation. This is also a question that they ask. And the other question they ask about amniotic fluid is the production of amniotic fluid. Okay, about the production of amniotic fluid. So remember that in the first 12 weeks, okay, first trimester, in the first 12 weeks, it is mainly from the transudate from the maternal plasma. It is always from the transudate from maternal plasma, mainly in the first 12 weeks. Then between 12 to 20 weeks, it is mainly from the transudate across the fetal skin, transudate across the fetal skin, from the fetal skin. And beyond 18 weeks onwards, it is mainly by the fetal urine. It is mainly by the fetal urine. So very, very important point to remember again, that in the first 12 weeks of intrauterine life, the amniotic fluid is mainly contributed from the maternal plasma as a transudate across the maternal plasma. Between 12 to 20 weeks, it comes as a transudate from the fetal skin. That is the main contributor. And from 18 weeks onwards, fetal urine becomes the main contributor of this amniotic fluid. So remember these three other important points about the amniotic fluid. Moving on to the next question. Question number 215. We're doing this question 215. Hypertonic uterine dysfunction is characterized by all of the following except. Okay, so whenever there are hypertonic uterine dysfunction, is there a prolonged latent phase? Yes, there is. Is there a prolonged active phase? Yes, there is. Are there less painful contractions? No. So less painful contractions are not there. It is saying hypertonic. Hypertonic. The name itself suggests. So the contractions are more. The contractions are more painful. Sedation being of greater value. Yes, that is also true. Whenever there are such hypertonic uterine contractions of which are very painful, which are increasing in intensity, but they're not leading to anything. You see, latent phase is not progressing, it is getting prolonged. Active phase is not progressing, it is getting prolonged. On the other hand, she is getting hypertonic contractions. She responds to sedation. Sedation being of greater value here than anything else. So let me just give you a brief here about what we are talking. We are talking about, in question, we are discussing question number 215, and we are talking about hypertonic hypertonic uterine dysfunction. We're talking about hypertonic uterine dysfunction. Okay, so this is what we are talking about. And you have to understand that let's just me tell you very important point about the normal contractions. What happens in the normal contraction vis-a-vis what happens when there are hypertonic uterine dysfunctions. So you understand in normal contractions, if this is the uterus, okay, the contraction, wave of contraction, it begins at the cornu, okay, then it combines here at the fundus, and then this travels downwards. Okay, so what has happened? There is a what is called as the fundal predominance. Okay, wave of contraction begins from the cornu and then comes together, and then there is a fundal predominance, and that will push the baby down. So fundal predominance, so contraction is coming, the wave of contraction is traveling from above, from the fundus down. So that is what is happening. Whenever there are hypertonic uterine contractions, this polarity, this fundal predominance is somehow lost. So remember, there are segments of uterus which are contracting here and there, but there is no fundal predominance, there is no wave traveling like this to push the baby down. So what happens is that maybe uterus is contracting like this, the uterus is contracting like this, instead of like this. So when the uterus is contracting, there is hypertonic uterine dysfunction. So contractions are there, yes, pains are there, yes, but there is no polarity, there is no fundal predominance. So these are hypertonic uterine dysfunction. So what happens is that the baby is not pushed down properly, the cervix doesn't dilate. So it leads to, despite the contractions, there is no progress in labor. So there is prolonged latent phase, there is prolonged active phase, and that is what happens in hypertonic uterine dysfunction. All right, so remember that in normal contractions there is, I told you, there is a fundal predominance. Okay, the pacemaker is at the cornu. Okay, the right one is more predominant than the left. And there is a wave of contraction, which travels at the rate of 2 centimeters per second, right? And this wave depolarizes the entire uterus, in 15 seconds. So now these are normal contractions. These contractions are able to dilate the cervix, these contractions are able to push the baby down. But when there is uterine hypertonic dysfunction, there is loss of this polarity and structure, and therefore there is painful contractions, right? But there is no progress. So there is prolonged latent phase and there is prolonged active phase, and it responds to sedation. Calm the uterus down and hope that the polarity is established again. Okay, so this is what happens in uterine hypertonic dysfunction. Now, moving on to the next question, we are reading question number 216. We are reading question number 216 now. Twin-to-twin transfusion syndrome may result in increased rates of which of the following sequelae? Twin-to-twin transfusion syndrome. A. Kernicterus in the donor twin. B. Cerebral palsy in the recipient twin. C. Necrotizing enterocolitis in the recipient twin. Or D. Meconium aspiration syndrome in donor twin. Now, let me just tell you, to answer this question, just first let us rule out what two things are not are not related specifically to twin-to-twin transfusion syndrome. And let us understand what is twin-to-twin transfusion syndrome. So we know broadly, in twin-to-twin transfusion syndrome, the two twins are sharing a placenta. When they are sharing the placenta, there are arteriovenous connections between the, arteriovenous connections in the placenta. So, one twin's artery is connected to the other twin's umbilical vein branches. Okay, so one twin can bleed to the other twin. That is what is the basic pathology of twin-to-twin transfusion syndrome. All right. So one twin will have problems because it is losing blood. All right, and the other twin will have problems because it is gaining an extra amount of blood. So these are the two broad categories of complications that they will have. Necrotizing enterocolitis and meconium aspiration syndrome, they are not specific to the twin-to-twin transfusion syndrome. Okay, so these complications are not very specific. They can happen to the twins because the twins can be premature. Meconium aspiration syndrome, there is no reason why one twin or donor twin or recipient twin, whichever twin, will have in meconium aspiration syndrome specifically. So these two complications, C and D, they are not specific to twin-to-twin transfusion syndrome. But Kernicterus and cerebral palsy, yes, that can happen. Now, which of these two among A and B is correct? Kernicterus can happen in the recipient twin, not the donor twin. I'll tell you why. And cerebral palsy can happen in the recipient twin. That is the correct answer. Cerebral palsy can happen in the recipient twin. All right. Now let us see. Let me tell you why this is there. Let us just read about. Let me just talk about twin-to-twin transfusion syndrome, and then I can make it clear. We are discussing question number 216. So we are talking about twin-to-twin transfusion syndrome, TTTS, and what is happening is that you have to remember that it is always in the monochorionic, diamniotic twins. Okay, these monochorionic diamniotic twins, they are sharing the placenta, and in these placenta there are deep artery to venous connections. Okay, so it is these deep artery to venous connections which are the problem. Okay, so you have here, let's say this is the donor twin, small donor twin, and this is the larger recipient twin. Okay, so from the donor twin, blood goes via the umbilical artery of the donor twin and goes to the umbilical vein of the recipient twin. So we have a situation where we have the donor twin bleeds into the recipient twin. Okay, so what is happening here? We can see the donor twin is stuck, called as the stuck twin. It is stuck in this sac here, so it has oligohydroamnios, and the recipient twin has polyhydroamnios. It is plethoric. Okay, because it is getting a lot of blood, it is receiving a lot of blood, it can have cardiac failure, right, and it can also have polycythemia. This twin will also have polycythemia, and after birth what can happen? Because of this increased polycythemia, there will be increased hemoglobin breakdown, and that can lead to Kernicterus after birth. Okay, it is because of this polycythemia that there can be kernicterus after birth. All right, and cerebral palsy, recipient twin will also have cerebral palsy. Okay, they will have cerebral palsy. There are many reasons for this cerebral palsy. One of these reasons is that polycythemia is there, so there is hyperviscosity. Okay, hyperviscosity and thrombosis, and that can result in vaso-occlusive damage and in the cerebral circulation, and can lead to this hypoxic damage because of that in the brain. So it is seen, cerebral palsy is seen in the recipient twin. On the other hand, the donor twin has IUGR. The donor twin has renal failure. Okay, the donor twin on the other hand will have renal failure. It will have less of liquor, and high drops can develop in both the twins. That is another thing. But important thing to remember, these are the important concepts to remember, that one twin bleeds to the other. There is one twin which is anemic with IUGR, with renal failure, with less of liquor, and there's a larger twin with multiple of complications developing because of circulatory overload. Circulatory overload in the recipient twin. That is why cardiac failure, plethora, polyhydramnios, polycythemia, and also cerebral palsy. Okay, now moving on to the next question. We are discussing question number 217. We are discussing question number 217 regarding hyperemesis gravidarum. False is allergic basis is suggested, hormonal imbalance may be a cause, small heart is an incidental finding, and may show manifestations of Wernicke's encephalopathy. Now the false statement is small heart is an incidental finding. This is a false statement. Okay, so let us talk about hyperemesis gravidarum a little bit here. We are discussing question number 217. We're talking about hyperemesis gravidarum. So hyperemesis gravidarum, a lot of etiologies have been suggested. One of them is allergic etiology, one of them is hormonal imbalance, right? What we know that hyperemesis, so these are two sort of etiologies which have been suggested. What we do know for sure that there is more beta HCG, then there is, whenever there is increased beta HCG, there is more incidence of hyperemesis gravidarum. So it will be more common in twins and molar pregnancy. Okay, there is increased incidence of hyperemesis gravidarum in twins and in molar pregnancies. Okay, and what will happen because of this hyperemesis gravidarum? A woman is vomiting, vomiting significantly, and vomiting to an extent that she is not able to contain anything inside, no solids, no liquids, right? And because she is not able to eat, and she is also losing out all the vitamins, right? All the vitamins. So there is increase in, what are the complications? Let us see what are the complications. The various complications in case of hyperemesis gravidarum can be because of this, that there are many pathologies. One, she is losing vitamins, and she is not eating, and she is not able to retain water also. not able to retain water also. So these complications will lead to, they can precipitate renal failure if severe. One thing is this. Then because of the actual act of intensive vomiting itself, she can have subendocardial hemorrhages, okay, because of those excessive vomiting causes increased negative pressure inside the thorax, so it leads to subendocardial hemorrhages. There can be hemorrhages in the hypothalamic region also, okay. And because of these two complications, there can be a small heart, or there can be a features of Wernicke's encephalopathy, okay. So small heart and Wernicke's encephalopathy can also happen in cases of hyperemesis gravidarum, and the small heart is a constant finding. It is not an incidental finding, all right. Now, what is the treatment? The treatment, if it is mild, one can give pyridoxine, okay, plus folic acid. We continue. And if it is severe, we will need to give antiemetics, like we can safely give we'll have to give metoclopramide, we can give ondansetron, and in severe she will also need IV fluid support, right, and because she is losing vitamins, she will need multivitamins also, IV multivitamins also, okay. So this is in short about hyperemesis gravidarum, all right. Remember, important points to remember is that there is increased incidence in twins and molar pregnancy. It is supposed to be, a lot of etiological bases have been suggested. One is hormonal, one is hormonal imbalance, one is allergic etiology. The complications are because of the act of vomiting, right, and because of the fact that she is not able to retain water inside, she is not able to eat, she is losing vitamins, right. She can, renal failure and shock can be there if this condition is not controlled. Subendocardial hemorrhages, Wernicke's encephalopathy can happen. Small heart being a constant finding in cases of hyperemesis gravidarum, and the treatment in mild to moderate. Mild and severe is a little different. Mild, we can try pyridoxine. In severe, we can go for antiemetics, IV fluid support, and IV multivitamin support as well. All right. Now, let us move on to the next question. Question number 218. So, we will now discuss question number 218. This is this figure question here. Let us see. Regarding the mode of contraception below, all are true except A, least failure rate, B, contains etonorgestrel, C, does not inhibit ovulation, and D, it is effective for 3 years. Now, the correct answer to this question is C, does not inhibit ovulation. So, question number 218, the correct answer is option number C. This is a false statement. This is a false statement. Okay. I'm so sorry about this. Where did that go? Just give me a moment. Yes. Yes, so this is a false statement here. C is the false statement. What is this contraceptive method we are looking at? This contraceptive method is an implant. And as we can see, this is a single rod inserted here on the medial aspect of the arm. We can see this. It is a single rod inserted onto the medial aspect of the arm. So this is implanon. Implanon is we are discussing question number 218. In the question, we saw a single rod implanted on the medial aspect of the forearm. And this is implanon. Okay, comes by the name implanon. Implanon is a etonorgestrel containing implant. Okay, there are other progesterone implants, but they have 6 rods. Okay, or that was the Norplant. Okay, 6 rods, that was the Norplants. There were 2 rods also, that was the Jadel. But most likely questions will now be on implanon only, because most of these Norplants and Jadels, they have been replaced by this implanon now, which is a single rod etonorgestrel containing implant. And the lifespan of this implant is 3 years, remember. And remember that this is the most effective, it is the most effective contraception. This is the most effective contraception, even better than sterilization. Even better than sterilization, the failure rate is around 0.01%. Failure rate is very, very low. And how is this failure rate so low? How is the failure rate so low? Now we understood that usually we have understood and we have known now that progesterone only contraceptions like Mirena, alright, like injection DMPA, they do not inhibit ovulation, okay, but etonorgestrel is one contraception, progesterone containing contraception that inhibits ovulation. So a contraception which is not able to inhibit ovulation will not have such a effective action, okay. So let us remember these 2 points together, that A, it inhibits ovulation, and because it is able to inhibit ovulation, it is very, very effective. In fact, it is the most effective contraception. So this is again important. Let us move on to the next question now. Question number 219. Let us see question number 219 here. Identify the type of abruptio placenta. Simple. This is a very simple question. As we can see here, what is happening in this figure? There is a placenta. Abruption is happening because it is prematurely getting separated, and we can see the blood is trickling down from one edge. Right, so this is what? This is marginal separation. The correct answer is option number B. This is marginal separation. As you can see, it is only from the margin. It is not partial, it is not complete, and it is not complete separation with concealed blood. If it would have been concealed blood, there would have been blood here. If it would have been partial, more of the placenta would have separated. Complete separation would have been clinical, would have been evident on the figure. If there was concealed blood, there would have been blood here, collection of blood here. Okay, so it is neither of these situations, so the answer is B, marginal separation. So we're clear with this. Let's move on to the next question. Question number 220. We are discussing question number 220. Identify the instrument. Identify the instrument. Now this is a instrument which is used for, this is the instrument that is given here is actually used for endometrial curettage. Now, endometrial curettage is actually not an instrument, okay. Endometrial curettage is a procedure. So, it is the instrument itself is a Pippel's aspirator. This instrument itself is a Pippel's aspirator, and this is used. This is a very thin instrument. This is the circumference is very thin, so it can you can easily pass it through the internal os, and no cervical dilatation is required, and that is why it is an office procedure. It is done in the OPD itself, and without any anesthesia. So it is a simple Pippel's aspirator. It is used for endometrial aspiration, but among all these options, obviously it is not a biopsy forceps. We are not biopsying anything. Biopsy. It is not a bone curettage. Fractional curettage is a procedure. Fractional curettage as a procedure you do under anesthesia. Okay, fractional curettage is a procedure which we do under anesthesia, and the dilatation of cervix is required because we have to introduce larger curettage instruments inside. Okay, curettes inside are to be inserted, and for that cervical dilatation is needed. And fractional, so we have to curette out all the walls of the uterine cavity, to curette out the anterior wall, posterior wall, lateral walls, not leaving any area of the uterine cavity uncurated. So that is the goal with fractional curettage. That is why it is done under anesthesia. Cervical dilatation is required because we want to insert curettes which are larger in diameter. Pippel's aspirator, on the other hand, is a method for endometrial office endometrial sampling, OPD level endometrial sampling, where we can go for aspiration of the endometrial lining and aspiration of the endometrium. So endometrial curettage, yes, is the answer. With fractional curettage also we are curating the endometrium, but among all these options, endometrial curettage is would be the correct answer by exclusion of the all else. But remember, this is a Pippel's aspirator. Also remember this point. Moving on to the next question, question number 221. Okay, which of the following tumors involving the female genital tract has the worst prognosis? Okay, worst prognosis. Remember, we're talking about worst prognosis. Dysgerminoma in a 35-year-old, uterine choriocarcinoma in a 25-year-old with a recent history of molar pregnancy, granulosa cell tumor in a 40-year-old, or a serous cyst adenocarcinoma of ovary in a 45-year-old. Okay, so let me just tell you one thing here. Let us just go through ovarian cancers. So ovarian cancers are epithelial in origin. They are from the sex cord stromal cells and from the germinal epithelium. So we have the germ cell tumors. Okay, so remember, let me just tell you here broadly what this question wants to ask you. We are discussing question number 221, and when we talk about ovarian cancers, remember broadly ovarian cancers, we are talking about the histological types. Okay, histologically, broadly ovarian cancers are of three types. We have the epithelial ovarian cancers, we have the germ cell tumors, and we have the sex cord stromal cell tumors. Okay, sex cord stromal cell tumors. And the age group of germ cell tumors is mostly in the reproductive age group, and with the sex cord stromal tumor, the women are in their 30s to 50s. So epithelial are the ones which peak in the 60s to 70s mainly. All right. Among all these three types, it is the epithelial tumors which have the worst prognosis. Overall, if I take broadly, talking about prognosis, these will have the worst prognosis, the epithelial ones, for many reasons. The most important reason, they are diagnosed usually very late. Okay, and by the time they are diagnosed, they have already advanced stages. So that is one reason why epithelial carcinomas, they have worse prognosis. When you talk about the germ cell tumors, overall germ cell tumors or germ cell cancers, like the better word will be cancers, I'm talking about cancers and epithelial malignancies. So not tumor, let's say cancers. So germ cell cancers, they are identified early. They are usually identified early because they grow rapidly. And other important point is that they have better prognosis. They have better prognosis and they are chemosensitive. Okay, the good point is that they are chemosensitive. So these two reasons, that because the fact that identify early, because of the fact that they are chemosensitive, they are obviously they will have better prognosis. Sex cord stromal cell tumors somewhere will have a prognosis in between the two. In between the two other types, in between epithelial and germ cell cancers, but majorly sex cord stromal cell tumors, they also have good prognosis. Good prognosis. So whose prognosis is bad? The epithelial cancers, right? Now coming back to the question, now let us see the question once again. Dysgerminoma is a germ cell tumor. This dysgerminoma in a 35-year-old in a reproductive age group woman has a good prognosis. Uterine choriocarcinoma in a 25-year-old with a recent history of molar pregnancy. Choriocarcinoma, highly chemosensitive, good prognosis. Granulosa cell tumor, okay, prognosis, let's say good only. What talking about the worst prognosis? So worst prognosis would be in the serous cyst adenocarcinoma. Serous cyst adenocarcinoma is an epithelial carcinoma. Okay, epithelial carcinoma, and that is why the answer to this question, this will have, among all of these, serous cyst adenocarcinoma is the epithelial type, and this will have the worst prognosis. Granulosa cell tumor is a sex cord stromal tumor, and your uterine choriocarcinoma, choriocarcinomas anyways have good prognosis because they are very chemosensitive, and dysgerminoma again is a germ cell tumor. Choriocarcinomas are germ cell tumors of the ovaries. Okay, now very important point again I want to emphasize here. If they ask you choriocarcinoma of the ovary or choriocarcinoma of the uterus, which has a better prognosis? Choriocarcinoma of uterus has a better prognosis because it is a uterine choriocarcinoma. Choriocarcinoma of the uterus. Choriocarcinoma can occur in the ovary as well. There it does not have such good prognosis as a uterine choriocarcinoma. Alright. Now, moving on to the next question. Question number 222. Alright. Now, a 15-year-old girl presents with a large unilateral adnexal mass and ascites. Which one of the following lesions is most likely in this patient? So, I right now told you reproductive age group, they are mainly germ cell tumors. If they are in the teenage girls, okay, so teenage girls also, germ cell tumors are the commonest in the commonest type of ovarian tumors in the teenage girls are also germ cell tumors. So in this question here we can see that Brenner's tumor is an epithelial, granulosa cell is sex cord stromal, serous cyst adenocarcinoma is epithelial, and immature teratoma is the germ cell cancer. So this would be the answer. and unilateral again, and ascites again. So this is why you know that germ cell tumors, they go to high sizes and big sizes, and they have ascites, they are picked up early. So let me just summarize here germ cell tumors for you. Let me just summarize germ cell tumors for you here again. We can continue with this finding itself. We have the germ cell cancers. Now these germ cell cancers, how are they, my question is, how are they different from the epithelial type? Okay, how are they different from the epithelial type? So how are they different? They grow to large sizes. They can be associated with pain because of those large sizes, the tense capsule. Therefore, they are diagnosed early. They are usually unilateral. They are very chemosensitive. They have good prognosis than epithelial. And another point of important, that conservative surgery is possible, and conservative surgery is also required in these germ cell cancers, because the age group that we are dealing here is women in their, from the 10 years of life to their 30 years of life. That is the age group that we are dealing with, and these women, they are in need for conservative surgery. They don't want to lose their ovaries and uteruses, so that is why conservative surgery is possible. Good prognosis than epithelial. They are very chemosensitive. They are usually unilateral. They grow to large sizes associated with pain. They are diagnosed early. So these are how the germ cell cancers, in a nutshell, they are, these are the few points in a nutshell how germ cell tumors or cancers behave differently than the epithelial ovarian cancers. Okay, epithelial ovarian cancers, on the other hand, they are not associated with pain. They are usually bilateral. They are not as chemosensitive as germ cell cancers. They have poor prognosis because they are, when they are picked up, when they are identified, it is usually too late. And conservative surgery is usually not an option for these women. And the age group of presentation with epithelial cell malignancies is also different. It is more common in the postmenopausal age group. Okay, so if you know this basic structure of if you know this basic structure, you will be able to differentiate between, some basic points between the germ cell cancers and epithelial cancers. But also remember which are the epithelial ovarian cancers, which are the germ cell cancers. Okay, so talking about which are the epithelial ovarian cancers and which are the germ cell cancers. Right, in the epithelial ovarian cancers, we have the serous type, you have the mucinous type histology. So it will be serous cyst adenocarcinoma, it will be mucinous cyst adenocarcinoma. Then we have the Brenner's is epithelial, we have the endometrioid, and we have the clear cell carcinoma, right, clear cell cyst adenocarcinoma. Among all epithelial, in the epithelial group, clear cell has the poorest outcome. Clear cell has the poorest prognosis or the poorest outcome. Which are the germ cell? The germ cells are the immature teratoma. Okay, germ cell cancers we are talking about. Okay, malignant. So immature teratoma. We have the dysgerminoma, we have the endodermal sinus tumor, we have the mixed cell, and we have the choriocarcinoma. Okay, so these are some of the germ cell cancers. Now moving on to the next question, question number 45. Sorry, question number 223, sorry, 45 is the statement. So let's move to question number 223. A 45-year-old woman who is 5th gravida para 5 seeks medical attention because of increased vaginal bleeding. On examination, her uterus appears to be normal in size. Which lesion is most likely in this patient? So she is 45-year-old, perimenopausal age group, multigravida, and there is abnormal uterine bleeding. So her uterus appears to be normal in size. So invasive endometrioid adenocarcinoma, is it leiomyosarcoma, is it adenomyosis, or is it simple hyperplasia? Now look, in a leiomyosarcoma, let's go to each option. Let us go to each option, okay. Considering invasive endometrial adenocarcinoma, if we consider invasive endometrioid adenocarcinoma, now this is CA endometrium in a nutshell. Now CA endometrium is unlikely. Why in this situation? Again, two reasons why CA endometrium is unlikely. Age of the woman. CA endometrium can happen in this age group also, but CA endometrium is mostly seen in the postmenopausal women. It can happen in the 45-year-old woman also. The woman, it is more common in nulliparous women, right? So our woman here is multiparous. Let's consider leiomyosarcoma. Leiomyosarcoma is a malignancy which arises in a fibroid uterus, okay. So the uterus obviously has to be larger, there has to be a huge mass. So whenever there is a fibroid which rapidly grows in size and suddenly from 4-5 centimeters suddenly enlarges to 10-12 centimeters, and especially in a perimenopausal or postmenopausal woman, we suspect that there could be an underlying cancer. But again, for that the uterus has to be larger in size. Adenomyosis is also a possibility in such a woman, but adenomyosis also the uterus has to be large. Okay, in adenomyosis also the uterus has to be at least a 8 to 10 week size uterus, and it is tender, it is globular, right? All these findings are not mentioned here. In leiomyosarcoma the uterus will be larger. Okay, invasive endometrioid adenocarcinoma, the uterus might not be big in size, but the fact that she is only 45, the fact that she is multiparous goes against the diagnosis. Simple hyperplasia. Simple hyperplasia is our answer. And another reason why simple hyperplasia is our answer is hyperplasias are more common than carcinomas. Okay, so in this woman, simple hyperplasia is our choice because of the simple reasons that simple hyperplasia will typically not be associated with uterine enlargement. Invasive endometrioid cancer inside the abdomen, if I have to choose based on these findings, invasive endometrioid adenocarcinoma, there can be uterine enlargement, okay. But the fact that she is 45, the fact that she is multiparous, the fact that uterus is absolutely normal in size, the answer is simple hyperplasia. And also simple hyperplasias will be commoner in this age group as compared to invasive endometrioid adenocarcinoma. So that is why the answer here. Moving on to the next question. Question number 224. Which of the following ovarian tumors has the worst prognosis? Now again it has come to the same question. We have discussed ovarian tumors so many times. Let us see. Dysgerminoma, immature teratoma, granulosa cell tumor, choriocarcinoma. Now I told you that choriocarcinoma of the uterus has a good prognosis, but choriocarcinoma of the ovary, okay, but choriocarcinoma, I'm so sorry about this, choriocarcinoma of the ovary has poor prognosis. So unlike, so we all have known that Choriocarcinomas of the uterus, good prognosis, very chemosensitive. But if the choriocarcinomas are in the ovary, that is bad prognosis, okay? Coming on to the next question, question number 225. The risk of Asherman syndrome is highest if DNC is done for the following conditions: medical termination of pregnancy, missed abortion, dysfunctional uterine bleeding, and postpartum hemorrhage. Now, the answer to this question is D, postpartum hemorrhage. Now, Asherman syndrome, what happens in Asherman syndrome? We are discussing question number 225. In Asherman syndrome, we know what is happening. Asherman syndrome, there are adhesions in the uterine cavity, okay, and these adhesions in uterine cavity have developed because of trauma to the uterine cavity. And important point to remember that there is damage to the basalis layer. This basalis layer of endometrium is the layer which is responsible for endometrial regeneration. If this layer is also damaged, it will lead to Asherman syndrome, because there's so many times women undergoes undergoes curatages for MTPs. There's so many women who go endometrial sampling, so many endometrial diagnostic procedures, and so many times the endometrium is curated out. But we don't keep curating till we damage the basalis layer. So usually those conditions, unless there are multiple DNCs, does not usually lead to Asherman syndrome. But curettage postpartum, curettage in the postpartum period. Now, what has happened in the postpartum period? After delivery of the placenta, the lochia has been shed, and what is there now remaining? The basalis layer, which is raw, which is open, okay, which is raw, which is accessible, and it is right there. Okay, so postpartum curettage, if we do a postpartum curettage, basalis layer is likely to get damaged because the superficial layer has already been shed. The postpartum uterus is soft, the basalis layer is there raw, open, and you curettage it out, it can lead to Asherman syndrome. Okay, so that being the logic of this answer. Let us move on to the next question, question number 226. Now this page has not looking nice. Let me just, yeah, better. Okay. Question number 226. A 27-year-old primee presents with pregnancy-induced hypertension with BP of 150 by 100 mmHg at 32 weeks of gestation with no other complications. Subsequently, her BP is controlled on treatment. If so, everything is okay. Okay, so she is controlled on treatment. She is at 32 weeks. There are no other complications. If there are no complications, the pregnancy should be best terminated at 37 completed weeks. Okay, so remember, clear scenario. I'm going to repeat the language of the question again. Remember, a woman with gestational hypertension, a woman with chronic hypertension or mild hypertension or mild preeclampsia, everything is okay. There are no end organ system changes. There are no end organ signs. The BP is well controlled on treatment, but still terminate once 37 weeks are completed. Okay, we do not keep waiting beyond that. But remember when to terminate early. Remember when to terminate early. So preeclampsia management. So preeclampsia management, remember that if the BP is controlled, if she is mild preeclampsia, and there are no end organ changes, and the baby is also doing okay, then you terminate at 37 completed weeks. Okay, but if the BP is more than 160 by 110, if there are end organ changes, okay, or there are end organ changes, she is labeled as severe preeclampsia. If a woman is severe preeclampsia and she is more than 34 weeks, you terminate. But if she is less than 34 weeks, we have to admit, control BP, give steroids, magnesium sulfate will be required if there is impending eclampsia, if there is HELP syndrome, okay, or if worsening end organ changes, or if worsening BP. Okay, so if she is less than 34 weeks with severe preeclampsia, our first goal is to admit, control BP, give steroids, magnesium sulfate should be given in these following situations. And if she is developing impending eclampsia, HELP syndrome, worsening end organ changes, or if BP is worsening, any time during our conservative management, right? So if 34 weeks of severe preeclampsia, we had started the conservative management, but any time the conservative management is failing, we will have to deliver. Okay, so the other question that arises, when do you deliver immediately? Immediately, irrespective of period of gestation. So deliver immediately irrespective of period of gestation if there is eclampsia, if there is HELP syndrome, no conservative management in HELP syndrome, if there is impending eclampsia, if there are worsening end organ changes, if there is uncontrolled BP, then you should deliver immediately irrespective of period of gestation. Okay, so this is about, in short, about the management of preeclampsia. Let us move on to the next question. Question number 227. Question number 227, a patient has had 2 first trimester and 1 second trimester abortion. Her screen for anti-cardiolipin antibodies is positive. Most appropriate treatment action for this woman. Now this woman with anti-cardio anti-lipin antibodies and with recurrent abortions, the diagnosis is that of APLA, and for APLA the most appropriate treatment is low dose aspirin plus heparin. The treatment is low dose aspirin plus heparin. This is the one which has evidence-based medicine behind it. There is evidence that such treatment helps. This low dose aspirin and heparin should continue throughout pregnancy. All right. There are certain second line management which are not they are second line management, so they are not first line. Those are IV immunoglobulins and plasmapheresis, but the best here is low dose aspirin plus heparin. That is useful for such a woman. Okay, now let us move on to the next question. Question number 228. This sonographic scan shows, this sonographic scan shows You can see here there is one head, two heads in one frame, and one body here, the other body here, two heads in one frame, twins. Okay, so nothing really to discuss here. This is sonographic scan, and you can see that there are two babies there in one frame. If the basic point is that, you know, it's easier right now to diagnose twins because these two babies, two heads can be there in one frame. Because the uterus is small, the babies are small. Even when the babies are larger, it is always said that should diagnose twin when you are seeing two heads in one frame. Okay, so basically that. Let us move on to the next question. A 45-year-old multiparous woman was subjected to endometrial aspiration doing workup for abnormal uterine bleeding. Histopath report can reveal all of the following except, now see, simple, okay. Secretory endometrium, yes. Cystic glandular hyperplasia, yes. Proliferative endometrium, yes. What about adenomyosis? Adenomyosis is not diagnosed on endometrial aspiration. Adenomyosis is presence of glands in endometrium inside the myometrium. How can that be diagnosed on endometrial aspiration? Okay, so whenever there is a woman with multiparous woman in this perimenopausal age group and she is being worked up for abnormal uterine bleeding, the most common finding is actually a secretory endometrium. Okay, secretory endometrium is the most common finding. Mostly there will be nothing. Okay, mostly there will be nothing. Then there can be hyperplasia. There could be proliferative endometrium also because of anovulation. Proliferative endometrium you will find because of anovulation. But adenomyosis, no, adenomyosis you cannot identify on endometrial sampling because the pathology in this in the myometrium. Okay, so what is the investigation of choice for adenomyosis on the other hand? Investigation of choice for adenomyosis is MRI. That is the investigation of choice, but confirmation of adenomyosis is only possible with hysterectomy. Hysterectomy and histopath. On hysterectomy specimen, the pathologist will say, okay, yes, the endometrial glands and stroma are lying inside the uterine myometrium. That will be the absolute confirmation of adenomyosis. Okay, ultimate confirmation, hysterectomy and histopathology. Investigation of choices, MRI. MRI can suggest but not confirm 100%. Okay, 100% confirmation will come from hysterectomy and histopath only. Now, moving on to the next question. Question number 230. A nulliparous woman in spontaneous labor was examined by you at 2 p.m. and was found 6 centimeter dilated. Okay, so at 2 p.m. she is 6 centimeter, 80% effaced with absent membranes, clear liquor, fully effaced cervix and vertex at 0 station. Oxytocin was started to augment the contractions. At 6 p.m., that means 4 hours later, she is reassessed and found to have same findings, but now with a caput. So same findings, but additionally now there is caput and grade 3 molding. Contractions have been adequate for the last 4 hours. What is the next step? So what am I diagnosing here? I am diagnosing here arrest of dilatation. I am diagnosing here arrest of dilatation. 4 hours of good contractions or adequate contractions, but no change in cervical dilatation. Okay. Alright, on top of that, there are findings which show that there is some problem with the head coming out. There is some amount of cephalopelvic disproportion, right? Because the caput is now forming, head is having difficulty negotiating. Grade 3 molding has started, okay? So, all these signs point towards arrest of dilatation, they point towards CPD. These two findings additionally point towards CPD. So whenever there is such a situation, you will take her to OT for cesarean section. Waiting and watching for another 2 hours, what will that do? That will do what? That will worsen the molding, that will increase the caput formation. If the molding is going to increase, the fetus is going to get hypoxic, more and more compression. Okay, tearing of the falx cerebri, and intracranial damage and intracranial bleeding can happen because of those situations. Oxytocin augmentation, what use is oxytocin augmentation in this situation? The contractions are already adequate. Vacuum delivery? No, there is already CPD. You try to pull out a head from the same path where the head is having problem coming out with. Okay, maybe you are able to take it out, but in the process we will lead to trauma. We will lead to trauma to the fetal head. We can lead to trauma to the trauma to the vagina and trauma to the maternal. Maternal trauma can be there, maternal perineal trauma to be there, and station is at 0. Okay, station is at 0. Such high station, high above. Vacuum is not applied there. Vacuum and forceps are applied once the head is at +2 station or more. So the safest, best option here is to deliver the baby by a cesarean section. For vacuum delivery, there should be no CPD. You cannot, when you are suspecting CPD, there is no forceps or vacuum instrumentation. Okay, so that is about this question. Let us move on to the next question. Okay, coming on to question number 231. All are true regarding aneuploidy screening except. Okay, now let us look at each option one by one, and the correct answer I will give you. Wait. So, all are true regarding aneuploidy screening except, let us look at option number 1. Nuchal translucency is a part of first trimester screening. So, first trimester screening is combined screening, which is nuchal translucency. Okay, is a part of that screening. So this is true. Okay, so this is true. Best overall performance is offered with integrated screening. This is also true. Biochemical screening in the first trimester is less sensitive compared to the second trimester. This is also true. Recommended for women of more than 35 years of age, false. This is the false statement. Obviously, women which are more than 35 years of age should definitely get it done. They are the ones who benefit the most. Okay, but it is aneuploidy screening is recommended, or it is advised for all women irrespective of their age. So aneuploidy screening is for all women irrespective of their age. All right. So let me just give you a brief here. Talking about aneuploidy screening. What are the important points that you should remember about aneuploidy screening? Remember that we have the first trimester combined screening, and first trimester combined screening we can do between 10 to 13 plus 6 weeks. And very important is it has nuchal translucency, it has beta HCG, and it has PAP-A. Okay. When these three are done together, it is first trimester combined screening. Okay. When we do only these two, only the beta HCG and PAP-A, then that is called as the dual screening. So this is the first trimester biochemical screening. Okay, NT is an ultrasonographic marker, beta HCG, PAP are biochemical markers. Okay, so when we do all three, it is first trimester combined screening. Earlier dual screening was there when NT was not a criteria, that was called as dual screening back in those days. You now usually hardly anybody is doing dual screening, everybody is going for combined screening. The second test is the second trimester screening methods, and we have the triple test and we have the quadruple test. Okay, we have the triple test and we have the quadruple test. The second trimester screening is done between 15 to 20 weeks. It can be done between 15 to 20 weeks. With the triple test, we have three markers as the name suggests. We have maternal serum alpha fetoprotein, we have the beta HCG, and we have the unconjugated estriol. In quadruple test, we have the above three, and plus we have the fourth marker, which is inhibin A. All right. So what are the important points I want you to remember? You have to remember these markers, okay? At least the components of these tests you should remember. Also remember what happens in Down syndrome. Remember, in Down syndrome it is high. Remember, high. So what is high? HCG and inhibin. Okay, so H for HCG is high, I for inhibin is high, HCG is high. Rest everything is decreased. Rest everything is, PAP is also low, alpha fetoprotein and unconjugated estriol are all, these three are all low. What is high? Beta HCG is high and the inhibin is high. Also, I want you to remember that when we compare biochemical screening in the first trimester versus biochemical screening in the second trimester, that is the triple test and quad test. So these tests are obviously better. Okay, these tests are obviously better. But if I ask you, let me give you an option. We have the integrated screening. In integrated screening, we combine the first trimester screening and the second trimester screening. This will give the best detection rate. This will give the best detection rate. If this is not in the option, after integrated screening, the second best is achieved by combined first trimester screening. And then the third best is by the quadruple screening. Okay, so just remember this sequence here. All right, integrated screening gives the best detection rate, second best is the combined first trimester screening, and the third best is the quadruple screening. Okay, so this is about the aneuploidy screening. Let us move on to the next question. Question number 232. False regarding calcium hemostasis in pregnancy is. So calcium hemostasis in pregnancy, what is the false statement here? Let us see. Serum non-ionized calcium levels fall, that is true. Okay, serum ionized calcium levels fall, that is false. Intestinal absorption of calcium is increased, that is true. Levels of 125 dihydroxyvitamin are increased, that is also true. So the false statement here is option number B. So right, you understand that in pregnancy there is an increased demand for calcium that the mother has to meet, okay, for the growing skeleton of the fetus. So that cannot be met by diet alone. All right, so what the woman does, woman increases its calcium, okay, calcium absorption from the gut. Okay, it increases the calcium absorption from the gut because woman does not want to give the calcium away from her bones. Okay, so woman increases the intestinal absorption of calcium, and that happens because of increased levels of the active form of vitamin D, which is 1,25 dihydroxy vitamin D. This helps to increase the intestinal absorption of calcium. Okay, but if the intestinal absorption of calcium is increasing, what is happening to the serum levels? The serum ionized calcium levels, they do not fall. In fact, the serum non-ionized calcium levels fall. Why do they fall in spite of increasing absorption? A, because everything is getting transmitted to the fetus, most of the calcium is getting transmitted to the fetus, more or less, there is decreased albumin. There is decreased albumin concentration. Now the non-ionized calcium that is there in the circulation is going to be bound to this albumin. The non-ionized form of calcium is going to bind to this albumin. So if the albumin concentration is decreasing in pregnancy, the non-ionized calcium levels are also the bound ones, which are the non-ionized calcium levels. They are in the bound form, they are bound to albumin. Albumin concentration decreases in pregnancy, and so does the non-ionized calcium levels. But the ionized calcium levels, they do not fall. The ionized calcium levels, they remain the same. Ionized calcium levels remain the same. If the ionized calcium levels are going to change, woman will go into tetany. है ना? The woman will go into tetany. The woman will have symptoms of hypocalcemia, but she doesn't. Okay, so despite the fetus taking most of the calcium that is there in the mother does so by increasing the calcium absorption, but the homeostasis is maintained in such a way that the mother should not suffer from the consequences of decreased calcium ions. Therefore, the ionized calcium levels, they are the same. Okay, the ionized calcium levels are the same, but the non-ionized levels, they decrease. And whatever the mother has to supply to the baby, that is met by increasing the absorption from the gut. Okay, so this is about the calcium homeostasis. Coming to the next question here, question number 233, name the ART technique shown in the figure. Now this is simple question. What is happening here? The egg, this is the egg is held in place by this pipette instrument, and you can see a needle is being inserted inside the egg. This is called as ICSI, that is intracytoplasmic sperm injection. It is not embryo biopsy right now. This is just an egg. This is not an embryo. There is no hatching involved here. So this picture is classical picture of the ICSI. There is no doubt about this. Needle inserted into the egg, and that is intracytoplasmic sperm injection. Okay, let us move to the next question. Question number 234. A 35-year-old woman, primigravida, during routine USG was diagnosed with twin pregnancy at 13 weeks. The following are true regarding this pregnancy except. So, this is a twin pregnancy at 13 weeks. We have to find out which is the false statement. Okay, we have to find out which is the false statement. Let us see here what kind of twins this is. I told you that these twins are, you can remember here, there is a membrane, amniotic membrane, which is a thin membrane separating the two twins. This is the T sign. Okay, here in this case, this is the T sign. This is a monochorionic diamniotic twins. Okay, so single T sign which is seen in monochorionic diamniotic twins. Okay, we understand that the chances of discordant twins are more. This is true statement. These monochorionic diamniotic twins, they usually have artery to artery anastomosis. This is also true. Zygosity, let us look at option D. Zygosity can be confirmed best by DNA fingerprinting. This is also true. No comment on zygosity can be made on this scan. This is false. So we understand that a monochorionic twins will almost always be a monozygotic. Okay, so in other words, let's say if it is a dizygotic twin, right, why this statement is true, why this statement is false? By this scan we can comment that it is a monozygotic twin. How we can comment? Because it is a monochorionic diamniotic placenta, monochorionic diamniotic scan. That is why we can say that the zygosity is monozygotic, because understand that when a twin is dizygotic, depending upon what time the division took place, this could be dichorionic, diamniotic, it could be monochorionic diamniotic. Sorry, if it is a dizygotic twin, it is always dichorionic diamniotic. But if it is a monozygotic twin, it could be dichorionic diamniotic, monochorionic diamniotic, or monochorionic monoamniotic, depending upon when the division took place. So in other words, you see that dizygotics are always dichorionic diamniotic. So if I begin the other way around, if I say if it is a dichorionic diamniotic placenta, it could be dizygotic or monozygotic. But if it is a monochorionic diamniotic, this is possible only with monozygotic. Okay, so that is what the question is trying to ask you, just in reverse. Okay, that if we know that the placenta is monochorionic diamniotic, on scan if it is a monochorionic placenta, there is very likely situation that it is a monozygotic twin pregnancy. Moving on to the next question. A 45-year-old female presents, question number 235, a 45-year-old female presents with polymenorrhea for 6 months. On examination, nothing abnormal was found. Which of the following is the next best line of management? In this woman, she has abnormal uterine bleeding, she has frequent cycles, polymenorrhea is there, she has frequent cycles, she has polymenorrhea. On examination, there is nothing abnormal, but before giving her any treatment, she needs a dilatation and curettage because she is 45 years old. So any woman with abnormal uterine bleeding more than 40 years of age needs curettage, needs some form of endometrial sampling to rule out hyperplasia. So to rule out hyperplasia, this woman, because she is in that age, because she is in 45 years of age, before we start any treatment, progesterone or OCPs or anything, she needs a dilatation and curettage. Okay. Moving on to the next question. Question number 236. Question number 236. Hart's rule is related to, the answer is mechanism of internal rotation. The correct answer is internal rotation. Okay. So what does the Hart rule say? Hart rule say that the levator ani, they come from the sides of the pelvis, the pelvic side walls, and they come and they descend down anteriorly and forward. They descend down anteriorly and forwards, and these are muscles, and elastic recoil of these muscles leads to anterior rotation of the fetal head, because the direction of the fibers is anteriorly and downwards like this. That is why the head also rotates anteriorly, right? So that is what is Hart's rule, that is the mechanism of internal rotation. Question number 237, atosiban is used for preterm. Atosiban is an oxytocin antagonist and it has been used for preterm labor. You know that oxytocin is responsible for uterine contractions, and that is why oxytocin antagonist, if you have that, can stop the preterm labor contractions, and that is why atosiban is used there. So pretty direct questions. Let us move on to the next question. A 55-year-old, question number 238. A 55-year-old lady presenting to OPD with postmenopausal bleeding for 3 months has a 1 by 1 mm nodule on the anterior lip of cervix. Okay, so there is a nodule. This is a clear-cut question. She is a 55-year-old woman with bleeding for 3 months. She has a nodule on the anterior lip of the cervix. The most appropriate investigation done to be done here is punch biopsy. Punch biopsy is our answer here. Question number 238. Punch biopsy. If you see a lesion, you are going to biopsy. That's the basic of it. Okay. So if you're going to see a lesion, you are going to go for biopsy. If in this question it would have said that there is nothing abnormal. Okay. There is no nodule. Nothing is seen. You would go for a pap smear there in that situation, but the best would be colposcopy. So punch biopsy is our answer here. So let me just tell you here that in our country, whenever there is a woman with, let me just summarize here, whenever there is a woman with postmenopausal bleeding, our focus is on the most common cause in our country is the CA cervix. So whenever there is a woman with postmenopausal bleeding, the first step is always a pars speculum examination, see a cervix. Okay. If there is a growth, we will biopsy the growth. If the cervix is normal looking, okay, if the cervix is normal looking, we take pap smear if not taken already. Takes pap smear if not taken already, if not done already, and you also do a TVS for endometrial thickness. Okay, TVS for endometrial thickness, very, very important. TVS for endometrial thickness, because she is postmenopausal bleeding, she could be endometrial cancer also. The other thing is that if the TVS is normal, right, and we should also go for colposcopy. Because she has postmenopausal bleeding. Colposcopy can be done, and she will be observation can be done. So colposcopy can be done, but if the TVS shows ET more than 4 mm, okay, she needs endometrial sampling. Very, very important. If the ET is more than 4 mm with postmenopausal bleeding, endometrial sampling should be done. Okay, so this is about postmenopausal bleeding. Okay, remember that there's a first step is a pars speculum examination. Obviously, if there's a growth, you biopsy. If the cervix is normal looking, take a pap smear if not already taken. Otherwise, also TVS for endometrial thickness, because cervix is normal. So the cause of postmenopausal bleeding could be inside the uterus. So that has to be evaluated. If ET is more than 4 mm, endometrial sampling. If ET is normal, if TVS is normal, ET is normal, then you can go for colposcopy and observation. Okay. Now moving on to the next question. Question number 239. All are true about Bandel's ring except. Now Bandel's ring is also called as the pathological retraction ring. It forms with obstructed labor. It is situated at the junction of upper and lower uterine segment. It is situated at the junction of upper and lower uterine segment. This is true. Uterus is tense. This is also true. Fetal death is usual. This is also true. Relieved by anesthesia, this is false. Okay, so this is the false statement and your answer there. Okay, so what happens in Bandel's ring? As we can see, what happens in Bandel's ring? What is Bandel's ring? Let us just see. So the head is trying to descend down into the pelvis. The fetal head is trying to descend down into the pelvis, but there is some obstruction. And the head is unable to. The uterus is pushing with forceful contraction, but the head is not coming out. What is this? We are dealing with obstructed labor. So what happens? The fundus, the uterine fundus, it starts thickening. Okay, so the tense uterine fundus, and what happens to the lower segment? The lower segment keeps dilating. Okay, and this is the fetal head which is trying to come down, but the head is not able to come down. So there is a ring, constriction ring, which is formed at the junction of the lower segment and the upper segment. With the time, over a period of time, if we are not acting at this junction, what will happen? The ring will reach here, and there is a tense segment up, and this is the fetal head which is just not coming down. Okay, so what do we see? That this ring, this is the dilated lower uterine segment and a tense contracted upper segment, and there is a pathological retraction ring, and there is a pathological retraction ring which is called as the Bandel's ring. The problem with this, the property of this ring is initially it was down here. Over time this ring moves upwards. This ring moves upwards at the lower segments, keeps dilating, and the ring keeps moving upward. Okay, and if this condition continues, what will happen? The uterus is tonically contracting, the mother is getting dehydrated, exhausted, the baby is the head is trying to come down, but the baby is compacted, crushed inside the uterus, not crushed literally, but yes, forceful uterine contractions trying to deliver the baby compromises the flow to the baby's heart, compromises the flow across the placenta. Such forceful prolonged contractions can compromise the flow to the placenta, then compromise the flow to the fetal heart and lead to fetal death. And also the trauma that the fetus head is undergoing in that negotiation through the birth canal, fetal hypoxia. So brain damage, loss, hypoxic damage to the fetus can lead to IUD. This whole tumultuous journey can lead to intrauterine fetal death. Okay, can lead to intrauterine fetal death. If this situation keeps on undergoing, this dilated segment can rupture. That will lead to maternal complications as well. So the treatment for this condition is to do a cesarean section. And even when you give anesthesia, this ring does not disappear. That is the thing. The ring that disappears on giving anesthesia is the constriction ring. Okay, so the ring that, so let me just tell you here. So this was about the retraction. Sometimes there is a ring called as the constriction ring. It is the constriction ring or the Schroeder's ring, which also forms important point of differentiation is that it also forms at junction of the lower uterine segment and upper segment, but it does not move upwards. It does not move upwards. It is felt on per vaginal examination and not on PA. The other important point is that it disappears with anesthesia. It disappears on deepening the plane of anesthesia. That is important. Right? So these are the differentiating features of constriction ring from the pathological retraction ring. Moving on to the next question. Okay, I think that is it. Question number 239. That was our last question. And with this, we have finished off the discussion of Grand Test 180. Thank you.